available on the MDH YouTube channel. We'll send out the link in the slide deck once the recording is up on the website. Before we formally introduce our speakers today, we'd like to go over a few of our typical MDH items. There will be one contact hour available for viewers. You'll receive the certification upon completion of the evaluation, and we'll drop that link at the conclusion of the webinar in the chat box, as well as send the evaluation link in the follow-up email we'll have. So first up, as usual, we want to go over the logistics. So your lines have been muted. Upon entry, we want you to stay muted, and you can type in questions into the chat throughout the presentation, and we'll keep track of those questions and save them for the end as long as time allows. Some quick MDH updates. So please continue to notify us with staffing changes and updates. The QI Awards program is live now, and we are accepting applications through the end of June. So June 30th is when we close, and we look forward to reading all about the awesome things happening at your hospitals. We want to thank you again for all your hard work. And without further ado, I want to introduce our co-presenters today. Please welcome Dr. Chris Streib, and the Cerebrovascular Director at the University of Minnesota Health-Fairview, and Sarah Engkjer, the Manager of Cerebrovascular Services at Health-Fairview. Pass this on to Dr.
Okay, great. Hi, this is Dr. Streib. Am I on? Can everyone hear me?
Yes, we can hear you.
Okay. And how do I'm not seeing the...
You can advance the slides. If you hover over the slide on the left-hand side, you'll see a number with arrows going up and down.
Oh, got it. Okay. Perfect. All right, I think we're ready to go. Thanks for the introduction. Thanks for asking us to present. We are happy to share our experience with Tenecteplase for acute ischemic stroke and kind of the pathway and the thought that went into it. For disclosures, I think this is already announced, but I'm the Cerebrovascular Director for Health-Fairview. I'm also the University of Minnesota Vascular Neurology Fellowship Director. Sarah Engkjer is the Manager for Health-Fairview Cerebrovascular Program. And we will discuss sort of off-label investigative uses of Tenecteplase and Alteplase. I will go through at least the current HAA guidelines, but for stroke, Tenecteplase is not currently FDA approved. So the learning objectives is to first understand the differences between Alteplase and Tenecteplase, two thrombolytic agents that are used to treat acute ischemic stroke. I know we are not supposed to use abbreviations TPA and TNK. They are in this in these slides just for saving space on some places, but so we'll be talking about Alteplase and Tenecteplase, and then we'll review factors that may support Tenecteplase utilization for acute ischemic stroke thrombolysis, including workflow pharmacokinetics and existing clinical trial data. And then we'll explain the implementation process for transitioning from Alteplase to Tenecteplase. So I'll start with a comparison of Tenecteplase and Alteplase, at least a sort of a higher level overview. And Tenecteplase is produced from native Alteplase, or native TPA actually, using recombinant DNA. So Tenecteplase is modified a protein at 3 different locations. This gives it favorable pharmacokinetics and a favorable pharmacological profile when compared to TPA. And this includes a 15-fold higher fibrin affinity, and I'll get into why that may be important. And it also has greater resistance to inactivation by a plasminogen activator inhibitor, which gives it a longer half-life, and that's why Tenecteplase can be administered as a single bolus rather than the bolus followed by an infusion like Alteplase. For some background, Tenecteplase is a first-line fibrolytic. It's used in acute MI, and this was from the ASCENT-2 trial that was published in 1999. And this was a comparison of Tenecteplase with Alteplase, and what they found actually was similar efficacy. The dosing is different than stroke, but the efficacy was similar with less systemic bleeding with Tenecteplase. And so since that time, Tenecteplase has been preferred for fibrinolysis with MI. And then more recently, the Extend IA TNK trial was sort of the first randomized trial of Alteplase and Tenecteplase, where it showed superiority of Tenecteplase over Alteplase And this is specifically in the setting of large vessel occlusion. And subsequently, there's been meta-analyses of the prior Tenecteplase Alteplase trials, which have shown non-inferiority compared to Alteplase. So if you have non-inferiority, why would we want to change to Tenecteplase? Well, it's much easier to administer, so it can facilitate treatment and transfer. It's delivered as a 5-second bolus push, and there's no infusion that's done afterwards. And then cost effectiveness is a consideration. So if you look at drugs.com, a 50 milligram vial of Tenecteplase is about $6,500, and a 100 milligram vial of Alteplase is a little over $9,000. Now, on the back end, there are some considerations. So Genentech replaces Alteplase that's mixed, but then not administered for an acute ischemic stroke patient. This is not applied to Tenecteplase since it does not have that same approval for acute stroke treatment. If a place were to mix Tenecteplase and then not use it because the patient got better, or for some other reason, then that cost goes against the treating hospital. I mentioned the pharmacokinetics briefly, and so I can go into that in a little bit more detail. But again, the pharmacokinetic profile is favorable in Tenecteplase, primarily because of increased fibrin specificity and decreased degradation in after it's administered. So a test was one of the smaller studies of Tenecteplase and Alteplase that was done in Scotland at a single center. And it didn't really show a benefit of Tenecteplase over Alteplase. There was probably some slight trend towards early neurologic improvement with the Tenecteplase group. And there was a trend towards less hemorrhagic transformation. But the trial itself was neutral. Probably was more interesting is they did a sub-study of 30 patients, and what they looked at was venous samples of different sort of clotting factors and different measures of coagulation. And they looked at these samples before the lytic was given, so before they gave either Alteplase and Tenecteplase, and then 3 hours after, 12 hours after, and 24 hours after the lytic. And they looked at PT, PTT, fibrinogen D-dimer, fibrinogen degradation products, plasminogen, and then factor V, plasminogen activator inhibitor 1 activity, and then F1 and 2, which are prothrombin fragments. And I'll just show you here what they found. So it may be a little bit hard to see, and I don't know if you can see my mouse, but these lines here that have the square and then the confidence interval with the square, those represent Tenecteplase, and then the lines that have these dots that are connecting at dots, circular dots, these are the lines that represent Alteplase. And so if you look at PT and activated PTT, you can see that the systemic change in coagulation factors in the patients that are receiving Alteplase, you can see that there is this systemic coagulopathy that's produced. And with Tenecteplase, you don't see that. And then with fibrinogen, you can see that there's not this change in systemic fibrinogen levels the same way there is with Alteplase either. And all of these changes are actually associated with hemorrhagic transformation. If you really increase your PT or your activated PTT, or you have really significant fibrinogen depletion, when patients are followed and these changes are seen, these people have higher risk of hemorrhagic transformation. Additionally, they looked at D-dimer, which is showing actual fibrinolysis, so that's a good thing. And you can see at 6 hours, the D-dimer level is higher in the Tenecteplase group, although they started at the same original level as the patients receiving Alteplase. Another measure of thrombolysis, so fibrinogen degradation product, again higher in the Tenecteplase group. And then plasminogen is also not depleted systemically with Tenecteplase in the same way as Alteplase, which shows that systemic clotting is intact. And then in the final slide, you can see with factor V, really no changes in the Tenecteplase group and a small change there in the Alteplase group afterwards. Plasminogen activator inhibitor, again, this is probably one of the more important measures. This shows that when you give Alteplase, your plasminogen activator inhibitor activity is really high. So that is actually an enzyme that is inactivating your fibrinolytic effect from Alteplase. And you don't see that again with Tenecteplase, and that gives Tenecteplase the longer half-life and allows the drug to be given just as a single bolus. So if we go and look now at the guidelines and we look at the update that was done in 2019, Tenecteplase is in the acute ischemic stroke guidelines in 2 places. So the first guideline is that it may be reasonable to choose Tenecteplase at a dose of 0.25 milligrams per kilogram over IV Alteplase in patients with who are eligible for thrombolysis and who are also undergoing mechanical thrombectomy. So this, again, is from the Extend IA TNK study. It's a very weak level of recommendation. The level of evidence B is from 1 randomized controlled trial, but 2B is, in terms of the AHAs, it might help, it might be beneficial, but it's not a strong recommendation. And we should really note that it's very specific. So the dose is 0.25 milligrams per kilogram, and it's only in the setting of patients presenting with large vessel occlusion that are also then going on to have mechanical thrombectomy. And the second place that Tenecteplase made the guidelines was a similar, very weak recommendation, a 2B, and again, from a randomized trial. And this is a different dose, so that complicates things. And it says Tenecteplase administered as a 0.4 milligram per kilogram single bolus dose is not superior or non-inferior to Alteplase, but might be considered as an alternative in patients with minor neurologic impairment and no major intracranial occlusion. So this is not in patients with large vessel occlusion, and it's for minor stroke, and it's a different dose. So it's pretty hard to reconcile these recommendations into a single hospital policy, although some places have implemented Tenecteplase in this fashion, where there's a certain dose for large vessel occlusion, and then there's another dose for non-large vessel occlusion, minor stroke. But certainly not the way that most sites that have implemented Tenecteplase have gone. So we'll discuss these trials here a little bit more. So the recommendation for 0.4 milligrams per kilogram dose of Tenecteplase in minor stroke really comes from NORTEST. It was a phase 3 randomized open label blinded endpoint trial that was conducted in Norway. And so these were adults that were otherwise independent, so a very pragmatic study. Essentially anyone that you're treating with thrombolysis who's otherwise independent was eligible. And they were either randomized to the 0.4 milligram per kilogram Tenecteplase dose or standard Alteplase. And then, a little bit of an oddity in the trial was this was published years ago prior to the wake-up trial, but they did allow wake-up strokes into the trial. So if you came in less than 4.5 hours, it was sort of conventional thrombolysis criteria. If you came in greater than 4.5 hours, I apologize, there's a typo on the slide, but it should say if you come in greater than 4.5 hours with a wake-up stroke and you have MRI flare mismatch, you are also eligible to participate in the trial. And if you look here at the slides, what you can see is that, for one thing, about 75%, so about 3 out of 4 actually had an acute ischemic stroke, and that most of the strokes were mild. So I blew up the tables here a little bit. If you look at the NIH stroke scale score and you look here at the mild group, over 3/4 of those patients had mild stroke. And if you look at the final diagnosis at discharge, 3/4 of the patients actually had stroke. And this is probably sort of the major criticism of NORTEST, which if you look at the outcomes, let me go back actually. So if you look at a trial like NORTEST, and you really want to see a difference between 2 interventions that you have, you want populations that are a little bit more sick. So mild stroke patients, whether they get Alteplase or even sometimes if they don't get Alteplase, tend to have a good functional recovery. And obviously, if you have many patients that don't have an ischemic stroke, then it's going to be hard to see a difference in your intervention in patients that don't have an underlying stroke. And these outcomes were measured with modified Rankin scale. And I think many people are probably familiar with this, but since we'll be talking about modified Rankin scale outcomes a lot, I thought I would just review it quickly. So this is a functional outcome score from 0 to 6. If your score is 0, you have no symptoms at all. You've made a complete recovery, and you're able to do sort of anything and everything without any sort of deficit. If you have a stroke scale of 1, you're able to do anything and everything that you want to do, but you do have some persistent deficit. An example would be someone who has numbness of their left hand, but it doesn't impact anything that they do on a regular basis. A modified Rankin scale score of 2 is slight disability, and so these are people that can't do everything that they did before, but are still independent. So maybe they're not, running, or maybe they're not doing some of the activities they had done previously, but they're still independent. And so this is considered to be, typically our excellent outcomes where independence is preserved. The next outcome, moderate disability. So this is people that are not independent but are able to walk without assistance. This is sort of a non-independent can ambulate, and a pretty good outcome depending upon how severe the stroke was. A modified Rankin scale of 4, so moderate to severe disability. They cannot ambulate, but they're not bedbound. And then modified Rankin scale score of 5 or 6. These are both bad. You're either severely disabled and requiring near constant care, or you don't survive. And so this is kind of the way that we conceptualize the modified Rankin scale. And this is the modified Rankin scale shift analysis for NOR-TEST. So if you look at the bottom of the slide, you can see the color codes for the different MRS scores. And you can see that if you are a shade of green, you are independent. And that's really where you want to be. And if you're transitioning towards, red or blue, those are outcomes that you don't want. And so you can look at these bars and you can see the shift, or in this case, you can see a lack of a shift, which is really what NOR-TEST showed. It showed no difference in outcomes between Alteplase and Tenecteplase. And you can see really here that about 3/4 of the patients ended up functionally independent, which is a reflection, really of the minor stroke or non-stroke in these patients that were enrolled. So the 2019 guideline, saying that 0.4 milligrams per kilogram of Tenecteplase can be used in minor stroke is really a direct extrapolation of the data from NOR-TEST. It's an interesting recommendation because the NOR-TEST study was actually not a positive study, and so that's why there's a qualification at the outset of that recommendation, saying that it's not been proven to be superior or non-inferior, but it may be reasonable. And this is just another table with more of the outcomes showing that symptomatic intracranial hemorrhage was also essentially the same. In addition to the MRS scores, the safety outcomes were very similar in this trial as well. So the next trial that I referenced previously is the Extend IA TNK trial. This was a study that was done in Australia and New Zealand. And these were adults with a modified Rankin scale score of 3 or less, so functionally independent or able to walk without assistance. And these patients also had large vessel occlusions, either the internal carotid artery, the M1 or M2 division of the middle cerebral artery, or the basilar. And patients had to get thrombolysis within 4.5 hours, and then they had to undergo endovascular treatment within 6 hours of stroke onset. And the primary outcome was reperfusion. So it was not a functional outcome study. What they wanted to see was if you got Tenecteplase or if you got Alteplase, what percentage of patients would have greater than 50% reperfusion of the penumbra or absence of retrievable thrombus at the time of the angiogram. And this is an open label blinded assessment trial. And this is sort of your classic large vessel occlusion study. The median NIH stroke scale is 17. It seems to always be 17 in every large vessel occlusion study. And you can see that the median time from stroke onset to initiation of thrombolysis was about 2 hours in both groups. And then the median time from initiation of thrombolysis to arterial puncture, so the time from when the patient received their thrombolytic medication to the time that the thrombectomy was started, was a little bit less than 45 minutes in both groups. And so that's important for the way we conceptualize this study. What this trial showed actually, again, is that there was substantial reperfusion in the Tenecteplase patient. So at the time of the angiogram, 45 minutes on average, after giving the thrombolytic, when they went to start the thrombectomy, 1 in 5 patients in the Tenecteplase group did not have retrievable thrombus that was still present. And so actually they ended up getting a diagnostic angiogram. They started the procedure, they took a picture, there's no clot, and so they stopped. And then in the Alteplase group, 1 in 10 patients had recanalized in advance. And that was their primary outcome that made this this a positive study. What they didn't expect, because it was actually designed to be a radiographic study, what they didn't expect was that this difference in effect would actually lead to a substantial improvement in functional outcome as well. And so that patients that were getting Tenecteplase instead of Alteplase actually went on to have better functional outcomes, really because of this this early reperfusion that we're seeing. So if you look here at the outcomes here, and you look at the modified Rankin scale score at 90 days, the median score in the Tenecteplase group was 2, so functionally independent, whereas the median score in the Alteplase group was 3, so they were able to ambulate independently, but they were not functionally independent in all of their other facets of daily living. And I think that this is actually sort of a really profound effect if we think about how this happens. So the ambulance comes in and they bring a patient to your CT scanner or your MRI scanner, and you activate a stroke code, and you see a large vessel occlusion, and so you give a patient Tenecteplase or you give a patient Alteplase, and then in 45 minutes alone, you're seeing a 22% reperfusion rate in Tenecteplase and 10% reperfusion rate in the thrombectomy group. After the thrombectomy, they had nearly identical reperfusion rates. And so the difference in outcome benefit that we're seeing is really in this 45 minutes between getting thrombolysis and starting your angiogram. And you can see that just that early reperfusion led to a 64% independent recovery rate in the Tenecteplase group versus a 51% independent recovery rate in the Alteplase group. And I think that's just a really remarkable difference, given that they all ended up going on to having an angiogram and thrombectomy afterwards, and it still wasn't able to bring that effect size down and make those outcomes a little bit more similar between the two groups. And then this is again a shift analysis, just demonstrating what we've already shown, that these MRS scale scores, these lower numbers that reflect independent recovery, are much higher in the Tenecteplase group than they are in the Alteplase group. If we look at death, then because of this early reperfusion and because of better outcomes, the rate of death was actually lower in patients getting Tenecteplase. And if you look at symptomatic intracranial hemorrhage or parenchymal hematoma type of hemorrhagic transformation, those rates are identical between the two groups. This data has really been shown to be sort of consistently present in other non-randomized studies. So this is a paper on Tenecteplase for large vessel occlusion, but specifically the basilar artery. And this was a registry comparison with Extend-IA TNK patients that had basilar occlusion. So it's a very small number of patients. You can see that there's 91 Alteplase patients and only 19 Tenecteplase patients. But the rate of reperfusion in the Tenecteplase group was 26%, and the rate of reperfusion with Alteplase was 7%, again prior to mechanical thrombectomy. And so again, a much higher rate of reperfusion in large vessel occlusion, which is likely due to the higher fibrin specificity of Tenecteplase. And this increased rate of reperfusion with Tenecteplase was actually despite much shorter times from giving thrombolysis to arterial puncture. So the Tenecteplase group had 48 minutes from the time that Tenecteplase was administered to the time that the angiogram was done and this outcome was ascertained, whereas in the Alteplase group, it was 110 minutes. So Alteplase had a considerably longer time to work and was still less effective than Tenecteplase in this non-randomized study. So since that time, I think really after Extend-IA TNK, that's when people became very interested in using Tenecteplase. And so a meta-analysis was published by Burgos, and this was published in Stroke in 2019. And it looked at the randomized controlled trials of Tenecteplase and Alteplase that have been done. So you can see in the middle there was a test, which I mentioned was a neutral study. I showed you the pharmacokinetic outcomes from a test. And NOR test, which we talked about initially, and then Extend-IA TNK. There's two other studies here which are important to know because they actually inform some of the information behind selecting the optimal dose for Tenecteplase. And so I will cover those here in a little bit. But basically, a meta-analysis was done of these 5 studies. And what they found was when they looked at non-inferiority. So when you look at non-inferiority, what you do is you define sort of an equivalent effect, which is this 0 line here on this graph. And then your non-inferiority bound is, the clinical difference that is not clinically relevant. And you can see this bound here is this blue line. And so the effect of Tenecteplase is reflected by that diamond. And so the first non-inferiority study they did was for Tenecteplase 0.1 milligram per kilogram. And in that trial, you can see that Tenecteplase, had a trend towards better outcomes than Alteplase. But because that diamond crosses both the 0 and the non-inferiority bound, you can't say from that trial that Tenecteplase would be non-inferiority at 0.1 milligram per kilogram. If you look at 0.25 milligram per kilograms, they have the Australian TNK trial ATTEST and Extend IA TNK, and you can see that that diamond there does not cross the non-inferiority bound. So at 0.25 milligrams per kilogram, there is non-inferiority of Tenecteplase when compared with Alteplase. And then at the 0.4 milligram per kilogram, which is really just the NOR-TEST study, it's hard to see in this visual, but that diamond does cross that bound, and so you can't quite say you have non-inferiority at that dose. And then finally here at the bottom, they pooled all the different doses of Tenecteplase and clearly were able to show also that there was non-inferiority for Tenecteplase at multiple doses compared to standard dose Alteplase. They also looked at symptomatic intracranial hemorrhage, and the problem with non-inferiority is you really need a lot of outcomes to prove something. So there were very few intracranial hemorrhages in all of these trials, numerically very similar between Alteplase and Tenecteplase. And so they were not able to say that that there was true non-inferiority, but what they were able to say is that there really is no numerical difference between symptomatic intracranial hemorrhage between these two treatments. And then this is the modified Rankin shift analysis. This also did not reach statistical significance, but there was a common odds ratio of 1.2 for an improved functional outcome with Tenecteplase. So a question that was commonly asked, I think it's being less commonly asked now, is what dose should you use if you're considering working with Tenecteplase? You saw the 2019 guidelines, and they do have 2 different doses that are in there. And going back, if we look at some of the dosing studies of Tenecteplase, the first dose escalation study was done in 2005. They used the 0.1 milligram per kilogram, 0.2 milligram per kilogram, 0.4 milligram per kilogram, and 0.5 milligram per kilogram dosing. And this study was stopped early because of low enrollment. But the one thing that we did learn is that the 0.5 milligram per kilogram dose was stopped early due to high rates of symptomatic intracranial hemorrhage. So the same investigator did then a phase 2b study, and he used the remaining 3 doses. Sort of an interesting study. Patients were randomized to one of these 3 arms and actually Alteplase. And the patients were compared between 0.1 milligram per kilogram, 0.25 milligrams per kilogram, and 0.4 milligrams per kilogram. And they got a certain number of points. So I think I have it here on the next slide. Maybe I don't. I don't have it. So if there was no good or bad outcome, and it was sort of a neutral outcome, then that specific patient got 1 point. If there was major neurologic improvement, then the patient got 2 points. And if there was deterioration or symptomatic intracranial hemorrhage, the patient got 0 points. And so as these doses advanced along this axis, they were able to say that the 0.4 milligram per kilogram dose was not as efficacious in terms of those outcomes as the 0.25 and the 0.1 milligram per kilogram dose. And this was primarily because of increased symptomatic intracranial hemorrhage and the 0.4 milligram per kilogram dose. Here I show the high rate of major neurologic improvement and the 0.25 milligram per kilogram dose. And then this is the safety data, and you can see in that 0.4 milligram per kilogram dose that there was a higher rate of symptomatic intracranial hemorrhage. This led to sort of the first randomized controlled trial in New England Journal of Medicine, a smaller study of 0.1 milligram per kilogram, 0.25 milligram per kilograms of Tenecteplase, or conventional Alteplase within 6 hours of last known well. And these are also large vessel occlusion patients, so they had to have a large vessel occlusion. They had to have a perfusion deficit on CT perfusion, and you could have an ACA, MCA, or PCA occlusion. And for that reason, they're moderately severe stroke. The median NIH stroke scale was 14. And it was also open label blinded outcome assessment. And it showed a pretty considerable impact with Tenecteplase. So when they looked at distribution of reperfusion rates here in this figure A, you can see that the 0.25 milligram per kilogram dose all the way over there on the right, you really had substantially more reperfusion than Alteplase. The 0.1 milligram per kilogram dose also had superior reperfusion as well, but not quite as well as the 0.25 milligram per kilogram. And then when they looked at changes in the NIH stroke scale, as you can imagine, better reperfusion leads to better stroke scale scores. And so you can see in the Tenecteplase groups that the change in the NIH stroke scale, which is negative, which is good, the decrease in the NIH stroke scale was significantly increased in the Tenecteplase groups. Also in terms of dosing was Extend IA TNK Part 2. So this is the same trial as Extend IA TNK Part 1, but instead of comparing Tenecteplase and Alteplase, they compared 2 doses of Tenecteplase in large vessel occlusion. And that was the 0.25 milligram per kilogram dose versus the 0.4 milligram per kilogram dose. And I don't think that I've mentioned it, but I should. In those doses, there is a max dose, just like Alteplase. And so the maximum dose for 0.25 milligrams per kilogram is 25 milligrams, and the max dose delivered for the 0.4 milligram per kilogram dose is 40 milligrams. And so same process, they gave 1 of 2 doses and then went on to have thrombectomy afterwards. And I was actually a little bit worried about this. We were already getting ready to implement Tenecteplase here, and I did think that conceptually that it would make sense that the 0.4 milligram per kilogram dose would be more efficacious, and we would have a more difficult question over how to dose patients, or we may have questions over whether or not large vessel occlusion patients were going to get a higher dose than non-large vessel occlusion patients. But the outcomes were actually almost strikingly identical in terms of functional outcome. And even beyond that, you could sort of guess that, okay, maybe the functional outcomes are similar because there's higher bleeding in the higher dose group, but more reperfusion. And that actually didn't really happen. So you can see substantial reperfusion is not blown up here. It's just on the top, but it's essentially the same in both groups. And then the symptomatic intracranial hemorrhage rate is higher in the 0.4 milligram per kilogram group. But that occurred in 7 patients, and 4 of those actually had wire perforation. So it was a technical complication of the endovascular thrombectomy rather than what we think of as sort of spontaneous hemorrhagic transformation. And so those numbers for symptomatic intracranial hemorrhage are actually quite similar as well, especially if you account for wire perforation. And so what this really reinforced to many people is that there was not a good reason to go higher than the 0.25 milligram per kilogram dose, and that would be adequate. So in conclusion, the trials that compared Tenecteplase and Alteplase either suggest numerical equivalence, non-inferiority, or superiority of Tenecteplase. The best evidence for dosing, in my opinion and most people's opinions, is probably at 0.25 milligrams per kilogram. It is likely to be most effective, or at least the data that we've seen so far is that it's most effective in recanalizing large vessel occlusion. And it's potentially more cost-effective and easier to administer. Again, it's really important to remember it is not replaced by Genentech if you mix but don't administer, unlike Alteplase. And there are further definitive randomized controlled trials ongoing. The projections pre-pandemic is that many of them would have been completed and presented at the International Stroke Conference this year. But obviously, the pandemic has led to either many trials being put on hold or very slow recruitment. So with that said, we have done a lot of work here, really led very well by Sarah Engkjer, who did a lot of the work here. And so I'm going to turn the presentation over to her to talk about the transition to Tenecteplase and planning and implementation.
Thanks, Chris. This really was a team effort to make this transition to Tenecteplase across the entirety of the Health-Fairview system. For a little bit of background, the Health-Fairview system is comprised of 6 acute stroke-ready hospitals, 1 primary stroke center, and then 2 comprehensive stroke centers. Our transition to Tenecteplase was actually a sub-project of our system-wide ischemic stroke care pathway. And that was a year-long project, that stroke care pathway that kicked off in January of 2020 with aims of improving clinical outcomes, reducing length of stay, and decreasing utilization of supplies and staff resources across all of our Health-Fairview sites. Some highlights in addition to transitioning to Tenecteplase with that project, we standardized our ED stroke code process across all of our sites. We standardized all of our ischemic stroke order sets across all of our sites, and then made that transition to Tenecteplase from Alteplase as well. So we implemented Tenecteplase as a part of this stroke care pathway in February of 2021. And I'll talk a little bit in one of the final slides about some of our preliminary experience. We're just coming up on kind of those first 100 patients. So we'll definitely have more data to share in the future. So one of our first steps in making the transition was actually to get buy-in from our key stakeholders. So we definitely had a very strong physician champion and advocate in Dr. Streib. I jokingly recommended that we buy him a Tenecteplase t-shirt on a couple of occasions. He was a really strong advocate for making this transition for the reasons that he outlined based on the evidence that he reviewed earlier. We also had representation and buy-in with our pharmacists. And so we have kind of two lead pharmacists in neuroscience across the system that also champion this and were really early partners. And then in addition, our nursing practice and clinical education team. So we've got a strong group of advanced practice nurses and clinical educators that also were on board early with this. And then our operations leaders in the neuroscience service line and emergency department. And then another key stakeholder was our EPIC or our electronic medical record informaticists and analysis. Those were really kind of our key partnerships that we needed to formalize early on in order to make this a successful project. Some of the key messages that I think really resonated with our stakeholders was, the evidence of equivalence and potential for superiority in patient outcomes, as Dr. Streib has discussed already. Cost effectiveness, that potential obviously was something that our administrative leaders and executive leaders were very interested in. And then the ease of administration, I think, was important for our operations leaders, our nursing practice and clinical educators, as well as those of us that are very involved in supporting our stroke certification process across the system. So that is something that I would recommend that if anyone has had any prior findings related to Alteplase infusion, that normal saline flush, our leaders on both the operations side and executive leadership teams were really excited about that ease of administration with Tenecteplase. Oh, sorry, I'm zooming in, not advancing. There we go. All right, so once we had buy-in from these groups, our next steps were really to kind of determine our standards across the system. As I mentioned, this was part of a larger project to really standardize our care for our ischemic stroke patients across all of our Health-Fairview sites. And so some of the key questions that we really had to consider and wrestle with within our stakeholder groups were whether or not to designate Tenecteplase as the standard IV thrombolytic, or if we were just going to make it an option. For us, we ultimately determined that from a cost effectiveness standpoint, as well as a patient safety standpoint, that making it the standard was the way to go. And so that's actually what we've implemented. And although Alteplase obviously remains on our formulary, Tenecteplase is now the standard IV thrombolytic across the system. We do have Alteplase available for use in research studies. If that would be an exclusion for any potential research study, we kept it available, but really limited the use to make Tenecteplase the standard. The dosing, Dr. Streib has talked about. I think when we first started with this conversation, that was more of a question than what it is now. But we have gone with the 0.25 milligrams per kilogram and the max dose of 25 milligrams, as Dr. Streib has stated. And then some of those questions about who will mix, do you need an order for your normal saline flush, since Tenecteplase is not compatible with dextrose containing fluids. And for us, rolling this out across a large system in the context of a pandemic, as well as a number of other strategies that were rolled out not only with our optimal care pathway in stroke, but there were other optimal care pathways rolling out. We determined that we would, at least initially, allow sites to continue their current process for mixing. So we've got some sites where nurses mix at the bedside. We have some sites where pharmacy mixes at the bedside, and then we have other sites where centralized pharmacy mixes. And for now, we've just left that process alone. Again, not wanting to change too many variables all at once and overwhelm our frontline staff. Ultimately, we determined that we did not need a separate order for normal saline flush. Those of you that have wrestled with that normal saline flush order with Alteplase and those findings on stroke certification visits know what I'm talking about. If you create an order for that normal saline flush, you're really forcing your frontline staff to have to document on that order, or it's potentially a medication error. And so we determined that putting the normal saline flush and clearing the line, ensuring that we're not mixing with any dextrose containing fluids, could be a part of the administration instructions. And really, we, had long discussions with both pharmacy and our nursing practice and education, and actually try to look at sort of comparable medications across the system to see if they included that normal saline flush as a separate order, and they did not. So ultimately, we went with that as an administration instruction rather than a separate order. Another point that we talked about was our blood pressure targets. This isn't something that has really been studied, and so we really had to use clinical judgment to kind of land on what our blood pressure targets were going to be for both pre and post Tenecteplase. Ultimately, we landed on that single target of 180 over 105. And the rationale for that is that because Tenecteplase is just an IV push, there's no infusion, we really want to have patients at that target blood pressure before we begin. And also, it is less opportunity for confusion. Even our stroke fellows, if you look in their workroom, had those Alteplase blood pressure targets for pre and post written on the whiteboard and cheat sheets, and I think just landing on this single standard is good from a safety perspective, and again helps theoretically, I think, with ensuring that patients are at that target right before the administration. So next steps for us in the process were really to focus on that Tenecteplase build in our electronic medical record. And so you'll see this is just a screenshot of our actual Tenecteplase order. Kind of all those key questions that I wrestled with, we've highlighted here in the actual order. So our dose of 0.25 milligrams per kilogram with that maximum dose of 25 milligrams is in the order. We have our blood pressure target to hold and notify our providers if that pre-administration blood pressure is greater than 180 over 105, and then those administration instructions, which include flushing the line with 3 to 10 mLs of normal saline before and after, and then just administering as an IV bolus over 5 seconds. I don't know how many of you have really had experience working with your Epic informaticist or your informaticist or electronic medical record IT folks. But this build actually was much more complex than I think what we had anticipated. And that's kind of been my experience when it comes to Epic and electronic medical records. The simpler it looks, the more complex it actually is behind the scenes. So it was really important for us to engage with that Epic team early and connect with them often. There was a lot of behind the scenes work that needed to happen for this build. One recommendation that I have that actually came from both our Epic team and our pharmacy team is to build out a separate ERX or ischemic stroke specific Tenecteplase order within your electronic medical record. It makes tracking much easier. And then also because the dosing for Tenecteplase in MI is different than what we're using for ischemic stroke, it helps from a patient safety perspective as well. So we don't have a provider inadvertently ordering a dose that is intended for a stroke patient, or that is intended for a patient having MI for a stroke patient. The other kind of challenge that we had, not only within our electronic medical record, but all of our other electronic and digital documents, was really to update that language from Alteplase to Alteplase and Tenecteplase, or IV thrombolytic. We've used that generic term. It's kind of like that Alteplase, as those of you who have worked on just updating your documents so you don't have TPA as an unacceptable abbreviation in your protocols and policies, have experienced. It's kind of like lurking in all places, like dark corners, like MRSA. So we literally had to pull all of our stroke related documents across the system and use the search and find feature to find where we had Alteplase and then replace that with Alteplase and Tenecteplase to make sure that we didn't have any issues with compliance, and also to ensure that it wasn't confusing for our staff. So that was also kind of a big step in the project that took more time than I think we had initially anticipated. So our next steps were really to communicate and cascade this change of information and clinical practice to our frontline staff. And for this part of the process, we really circled back and partnered with our key stakeholders. We had to have messaging out for pharmacy, for ED nursing, for ICU nurses, for our flyers, resource nurses, operations leaders. And so it was really important that we partnered with those groups to ensure that our messaging and our reason for the change and those key practice changes were reaching frontline staff. So I think one of my recommendations is when you're making this transition, include the why behind the practice change. I think that always helps staff to really adapt that process change. We know it's work to change your practice. So I think including that why, that it's potentially superior to Alteplase, the ease of administration, the potential for cost savings. Those were all important messages for our frontline staff to hear. The other thing that we did that I think really helped frontline staff kind of transition and adopt this process is we did a compare and contrast on our learning module that we assigned as part of our mandatory annual stroke education to all of our staff across the system. So we compared and contrasted the differences between Alteplase and Tenecteplase, just real high level, but I think that was an important topic to cover in that education for staff. The other thing that we did is we did just-in-time education, or we really used it and took advantage of those quick 15-minute, 10-minute, 5-minute huddle conversations that are a part of our daily engagement system across Health-Fairview. So this is where our stroke program coordinators across the system were really key. They went to the emergency department, they met with frontline staff, they had those quick, important, high-level messages that they did just before our go live. And I think that helped to really reinforce that process that staff had up until that point kind of just received through email communications and then their learning module. And it was interactive. It gave staff an opportunity to really ask questions, and it was good feedback for us as well in the planning. So this is kind of a format that we've adopted not only for the rollout of Tenecteplase, but we actually use it in telestroke as well, where if you have a daily safety huddle or daily meeting that happens in one of your units or departments, if you come up with a 3-minute message, talking points, and you roll it out on 3 consecutive Fridays, you're going to reach a majority of your staff. And that is a strategy that has worked really well for us on multiple projects. And then anticipate that you're going to need to provide some support post go live, and then take time to celebrate. We spend a lot of time, I think, in the basement focusing on those problems that need to fix. And we really need to ensure that we're also taking the time to be in the balcony and celebrate those transitions. So that's another strategy that you'll want to, I think, incorporate in your plan. This is just an example of that compare and contrast between Tenecteplase and Alteplase that our clinical education team put together for that learning module that went out system-wide. And I think it just very nicely summarizes those key differences between Tenecteplase and Alteplase for staff. So just a little bit about our early experience. So I have just included a slide on our overall IV thrombolytic utilization by site. So we are really coming up on, I think, our first 100. We've probably hit it sometime over the weekend, Tenecteplase administration. And so I think, part of what you're seeing is our overall thrombolytic rate really dipped in Q3 and Q4 of 2020. I think that is really an effect of the pandemic. Our stroke code volumes were down, our ED volumes were for non-COVID reasons were down during that time. And then really we saw just at the beginning of the year, and particularly as we made the transition to Tenecteplase, those numbers have really rebounded and bounced back up to pre-pandemic rates. So our stroke program coordinators are responsible for reviewing every case across the system when an IV thrombolytic is administered. And overall, as far as potential adverse events, we've had one patient where we had to utilize our post-thrombolytic angioedema order set, and that patient recovered without any negative impacts. And then we have not had any instances of symptomatic ICH at this point. For perspective, between our comprehensive, our busiest comprehensive and our busiest acute stroke ready sites last year, in 2020 had a total of 4 cases of the symptomatic ICH. So again, we're seeing kind of that safety profile that we would anticipate given that evidence that we discussed earlier today. Other considerations that I just wanted to point out, make sure that you continue to include Alteplase and TPA as synonyms for key searches in your electronic medical record, whatever repository you have your policies and protocols in. The last thing that we wanted is a doctor to type in TPA during a stroke code and not have an opportunity to and not have it pull up the right order set. That's not what you want. So make sure that you keep those synonyms in and link those to your Tenecteplase orders and protocols in all of those areas. Obviously, you need to keep Alteplase on the formulary. That is a Joint Commission requirement. So for sites that are certified by the Joint Commission, I just wanted to reiterate that. If you're defaulting and going to choose Tenecteplase as your standard IV thrombolytic, really default or kind of lock that down in your electronic medical record, and then again clearly indicate that it's for ischemic stroke in your labeling. I think that is an important safety feature. And then again, I think I mentioned that we use Epic, but we created a panel to link our post-thrombolytic monitoring orders with the actual medication order. That wasn't something that we had to do because we were transitioning to Tenecteplase, but that was a safety gap that we recognized that we needed to address. And so now, because we've linked those important monitoring orders, Q15-minute vital signs, Q15-minute neuro checks, when to contact the doctor, with the actual Tenecteplase order, we don't have to worry about any gaps in care and misses there. And then one last consideration is to really develop standard language for your reason for selecting Tenecteplase, for your documentation, for your stroke registries, for the Minnesota Stroke Registry, Get With The Guidelines. I think the options right now in Get With The Guidelines are for potential large vessel occlusion, minor stroke, and then other. And then if you, at least in Get With The Guidelines, if you select other, you need to give more reason for that. For our system, we have landed on that it's our system standard IV thrombolytic. You could also, use any of those other reasons that we covered kind of as the reason why for making the transition. So safety and ease of administration, large vessel occlusion, all of those I think would be acceptable to fill in that other section in your registries and documentation. But that's another consideration that you'll just need to account for in your implementation plan. So that's all that I have. I think I know we're right at time. Allie, do we have time for some questions?
Yeah, we're at time. I don't see any questions in the chat yet. So if I do get any questions, I can forward them to you too as well. I don't see anything at the moment. So we might just wrap up then if that's all right with you two.
Yeah, that's great. One thing that I would add, Dr. Streib and I have our contact information on the slide. We also are one of our pharmacists, and then our stroke program coordinators and our clinical practice and education folks have also offered to share their experience with this transition. Their perspective obviously may be a little bit different. So please feel free to reach out to me or Dr. Streib, and we can get you in contact with those folks.
Thanks, Sarah, for that. There's one question in the chat right now. Do you have time for a quick question?
Yeah, we can look at it. I was just reading it. Hold on, it's kind of really small on my screen here.
I can answer the reimbursement one.
Yeah, go ahead.
So we did a cost analysis prior to implementation. Dr. Streib mentioned that Genentech does not reimburse for Tenecteplase waste, and we did not. It was a favorable cost analysis for our system, but that is something that pharmacy will want to look at. One thing that we had not anticipated for our sites that were mixing Alteplase in centralized pharmacy, they were repurposing the unused portion of the vial. They were under hood in a clean room, but they were repurposing that for line clearance. So that was one consideration that came up in that cost analysis that I think kind of surprised us. So just an awareness that it's really important to partner with your pharmacy on that.
Yeah, and and sort of in terms of reimbursement with FDA approval, that's come up. I think it's sort of worth remembering that there's no FDA approval for the 3 to 4.5 hour window for Alteplase, and we actually, prior to this and still are, we do delayed window thrombolysis. We have sort of 30 cases beyond 4.5 hours, I think. And so all of those are not FDA approved, and so I think that from my standpoint, kind of FDA approval and reimbursement are not really tied together that closely. We haven't seen any problems. There are places that have been using Tenecteplase longer than us that have not seen problems, and so I don't make promises on that end, but I think experience from other sites would suggest that's probably not an issue. And then the last question was, did we change any protocols for looking at post-Tenecteplase management for symptomatic intracranial hemorrhage given the longer half-life? As we mentioned initially, the only thing that we did change is we made the pre-administration blood pressure the same as post-administration. Again, there's really no pre and post. You give Tenecteplase and it's in, you're done. So that was easier and kind of something I'd wanted to do anyway. In terms of symptomatic intracranial hemorrhage, all studies, if you look at them, again, it's either equivalent to Alteplase or probably trending slightly lower. And so because of that, the safety profile that exists, we really haven't made any changes. So we've really interchanged the Tenecteplase at the 0.25 milligram per kilogram dose for Alteplase at the conventional dose. And we made the blood pressure change here locally. I don't think most places have done that. So there's not really other changes to what we've done in terms of thrombolysis eligibility criteria or post-thrombolysis care, really other than changing out the thrombolytic agent. All right, I don't see any others, so I'd like to thank everyone. Oh, maybe there are others now.
There's just one that I can see, and it is post-care the same for Tenecteplase as for Alteplase.
Yeah, again, for us it is. I know some people who are using Tenecteplase at their sites as well. I'm not aware of anyone who's made any changes related to that. So it is for us, and at least at the sites that I've been in communication with, it is for them as well.
Great.
Oh, I think there's one question about, other than the Joint Commission requirement, is there another reason to keep Alteplase on your formulary? I would say probably yes, and that's one that I would partner with your pharmacy team, and there are other uses for Alteplase. So that's one that you'll need to, I think, really partner with your pharmacy on and determine what's being used in your institution. For us also, because we enroll in clinical trials, we wanted to make sure that it was available in case a trial came up that Tenecteplase would have been an exclusion for whatever reason. So it's also still available for that reason.
Thank you so much. I don't see any other questions at the moment. So with that, I just want to thank Dr. Streib and Sarah for today's informative presentation. A lot of research, time, and effort went into this. It's a big deal. I just want to let you know that everyone, there's an evaluation link that Mimi has put in the chat. And once you fill out the evaluation, you'll receive a certificate for the contact hours. Again, we'll be sending a follow-up email with the evaluation link and access to the recording and the slide deck. And thank you for attending today's webinar. And thank you again, Sarah and Dr. Streib. We really appreciate you giving us the time.
Great. Thanks for having us.
Thank you.